Okay, so love this PowerPoint. It's probably a little over your head, and I didn't give you a copy of it because it's a lot, but I just want you to pay attention. You have the information you need off your PowerPoint. I just want to see how it is applied. So we do have four categories of liver tests. I talked about the AST, ALT specifically. There are also, that is for hepatocellular damage. There's also tests for cholestasis, which is gallbladder disease. We can look at alk phos with that and GGTs. What about biliary excretion? So then we worry about, are they looking jaundice? We're going to see what the bilirubins are reading. And then also liver function. Remember albumin, the making of proteins, and also PTINR because that is the coagulation readings. So we went over ALT mainly from the cytosol of the hepatocytes and other organs. It's more specific than AST for acute and chronic liver injury. AST is from cytosol and mitochondria of hepatocytes as well as other organs, skeletal, muscle, heart, kidney, brain, pancreas. Okay. So when we have, these are called your aminotransferases. That's your ALT and AST. We call them aminotransferases. They're enzymes and they indicate inflammation or injury to the hepatocytes. So damaged hepatocytes will leak into the contents of their interstitial spaces and in the plasma, and that fluid actually gets reabsorbed into the circulation. So we'll go ahead and we'll draw a red tube. We do know that usually the values, the ones that I gave you on the PowerPoint are the ones I want you to go by, not this. But just remember, men tend to be a little higher in it. And it could be because of the muscle, right? Typically they have a more muscle mass. The lowest ratio of AST to ALT occurs in the liver. So ALT is in order and concentration is mostly in the liver. I love that the L's in there. Then the kidney, then the myocardium, then the muscle. AST is higher in the heart, then in the liver, then in the muscle, then in the kidney, then in the pancreas, and then in the spleen. So if you see a serum AST that's greater than ALT, there's two important situations. Alcohol use most of the time, and then cirrhosis. Okay. So things that indicate hepatic synthetic function, but not necessarily inflammation or injury. So a true liver function test is also including not just AST and ALT, right? Because you saw they were in other organs, you do have to look at albumin. That's where the liver makes the proteins, and the bilirubin, because the liver will conjugate the bilirubin and then store that in the gallbladder. And then the PTINR is another big important test that we need to look at because the liver makes those clotting factors, including the prothrombin. So does it look like it's something acute? Does it look like it's something chronic? Is there anything in their social history or past medical or medication list that thinks, what could be going on? Does it look like it's a gallbladder problem or does it look like it's more of a liver problem? So when you look at these alcoholic hepatitis, look how much higher. It's double. The ASTs are usually double the ALT. If it's an autoimmune hepatitis, your ALT is going to be higher. If you're looking at chronic hepatitis C, higher. If you have viral hepatitis, ALT, higher. When we look at alcohol and Tylenol toxicity, you're looking at AST higher. Acute hepatitis, it's even. And that's the one that I told you was contaminated waters. So if you look here, chronic liver disease prevalence, the most common is going to be your non-alcoholic fatty liver disease, most prevalent. And then we have non-alcoholic steatohepatitis, chronic hepatitis, alcoholic liver disease, and then chronic hep B. And if you look at hepatocellular cancer, good amount. In 2004, it recorded 19,000. Okay, so these are the different things. So key tests for chronically elevated liver enzymes, if we see them elevated all the time, chronically, we're going to think of somebody that may have some kind of group where they're at risk. So did they have, high sexual activity when they were younger? We called them you know, the the hippie time, right? So for hepatitis C, the age group for there is 1945 to 1965. So these are your seniors now. So now if they have a few symptoms, then they should be screening, and they are screening them even if they have no symptoms. So we do know that we can have the hepatitis B surface antigen means that we have a chronicity of hepatitis B. If it said hepatitis B SAB, that means you were vaccinated, but this is the actual antigen. So also a hepatitis C. And when we do the alcohol history, we do CAGE is, have you ever tried cutting back? Do you get angry that people are always harassing you about alcohol? G is, do you feel guilty for drinking? And do you need an eye opener? So these are usually like a drink in the morning. These are usually questions we ask for risk. Also medication and herbals. Herbals can do it. We also want to check for BMI, hypertension, lipids, anything like that. So if they're acute, like they were always normal and now they're acutely elevated, we would want to do tox screens, acetaminophen levels, and hepatitis A, because remember that's an acute thing. You know, you eat something that might be contaminated or drink bad water, you can get sick. We would also check an alcohol blood level. If they had a heart attack, we would want to check that and also check for meds. Okay, so I just wanted to give you a little application into this. This is good, but it's a little too, I think it's a little too much for you um, to wrap your head around. But I'll give you this one. How about this? 19-year-old female college student with fatigue, new onset jaundice, itching from the ammonia going into the skin. A few days duration, no alcohol on board. I know you're surprised, 19-year-old college student, but they're on minocycline, which is a tetracycline based for acne, and then multivitamin. No history of contacts with people that had viral hepatitis. They had miral ichnus or yellowing of the eyes. No, hepatosplenomegaly, normal bowel sounds. There's no tenderness or masses in the abdomen. So they checked the albumin. They checked the bilirubin. The alk phos is up a little bit. AST and ALT are elevated. So if you look here, the hemoglobin was okay at 13, white cells at 5,000, that's okay. Platelets at 2,000, that's fine. But we definitely see some elevations of bilirubin and especially the ALT. So that would lead me to think something, is affecting the liver. And acute viral hepatitis were negative. Okay. So what we found out was it was a drug-induced gallbladder issue secondary to tetracycline. So once they stopped the drug, liver profile went back normal in 8 weeks. What is the most common cause of drug injury, drug-induced injury to the liver? Um, it's mostly, the cause is most often intentional or unintentional. What do you think? I would say unintentional. People think that Tylenol is safe. They'll take it. And actually, if you exceed 4 grams, which is 4,000 milligrams, because now these ones for arthritis are like 800 milligrams each, and people are taking two like every 6 hours, we're going to have this problem. So believe it or not, drug-induced liver injury, most common cause is Tylenol because it's over the counter, it's so easy, and we use it for a lot. And we have to remember also in multi-symptom cold relievers, it's in there. And then our narcotics ones like Tylenol with codeine, Percocet, Vicodin, it's in that too. So Tylenol, statins can increase. We do check liver enzymes when they're on statins. Glucophage. Glucophage is metformin. It's an anti-diabetic medication, and that med is actually metabolized by the liver. Minocycline for acne, it is a tetracycline. And then fat-soluble vitamins in high doses. So when people take too much A, D, E, and K, this also can happen. Okay, that's it.